let me welcome and introduce Dr. Tayyeba Idrees, who is going to present her presentation on the case study of universal health coverage and healthcare insurance in United Kingdom. And I hope that her session will delve into the key aspects of universal health coverage and healthcare insurance in a developed economy, offering valuable insights and practical takeaways. Dr. Taiba is a highly dedicated and accomplished medical professional with a dual qualification in medicine and a master's in public health. And with a strong foundation in her clinical practice and advanced expertise in public health, she brings a unique blend of medical knowledge and population health insights to her work. And Dr. Taiba is passionate about creating impactful change in the community health and continues to advocate for sustainable, inclusive, and data driven public health policies. So, Dr. Taiba, I welcome you again, and the stage is yours. Thank you.
Thank you so much. Everybody can hear me?
Yes.
Okay, so my topic is today is about the universal health coverage, which is UHC, and healthcare insurances, sustainable healthcare financing, and the governance. As you know, my name is Dr. Tayyeba Idrees. I'm public health consultant, healthcare counselor, and founder of WNF. Today, our focus is about UHC in London, the case study, the sustainable healthcare financing, the governance importance, and the special situations like the pandemics and the wars and the disasters. Before going into the detail, we will look into that what is universal health coverage, which is basically to ensure that all individuals can access the essential health services without any financial hardship or any discrimination. So universal health coverage means that all the people receive the health services they need without suffering from the financial hardship. It is a strongly promoted by the WHO, and it is a key target under the sustainable. It is the goal 3. So what is the perspective? Public health perspective of UHC is from public health viewpoint that UHC is not just about to treating illness. It focuses on population level, like how to improve the prevention, how to reduce inequalities. And the main emphasis of them is to prevention over cure, community-wide interventions, and addressing social determinants of health like the income, like the education, and the housing as well. So what are the components of UHC in public health? They have to make sure that treat the illness in a very beginning. Like if you will promote health instead of spending money on their treatment, that would be more worth. So encouraging healthy lifestyle, like improving through the diet, exercises, no smoking, by preventing diseases with the vaccination, with the campaigns, with the awareness campaigns as well, with the treatment services and rehabilitation as well, and palliative care, which is improving the quality of life for the terminal illness people. So what are the dimensions of UHC? They cover the population coverage, like who is going to be covered, which is the particularly population which is going to be focused. Services coverage, like what services and which is the proper time to give that services. And financial protection is how much cost it should have to be covered. We'll take an example of United Kingdom, that under the UHC, when we will talk about United Kingdom, we will say that National Health Services, which is NHS, provides the free healthcare at point of use. They are being funded through the taxation, and that covers 100% of the population without any discrimination of like the gender discrimination or the status discrimination. So what are the success? They are like the vaccination rate are too much high, like they are 100%. Low infant mortality, there are less than 3.6 per 1,000 live births. What is the importance of public health? Say they can used for the reduction of health inequalities, prevention financial catastrophe, and improve population health, support the economical growth, and they are the major factors, you can say, in any community which can make their population healthy. So what are the key public health indicators to reduce related to the UHC? They are improving their life expectancy. Infant mortality is going to be improved. Maternal mortality ratio is going to be improved. Immunization coverage has been increased. Out-of-pocket expenditure is going to be improved as well. In the form of global statistics, we will see that 4.5 billion people lack full access to the essential health services. About 100 million people fall into extreme poverty, which each year due to the healthcare cost, and half of the world population receive essential health services. So as the public health team, we should know that there should be a policy that should have to eliminate such problems which are like people are facing, like discrimination, like if why they have to spend money on front, they should having some taxation system, they should having something insurance system which make sure them that whenever they are going through any problem or any emergency, they can be treated in an emergency as well. So if we will take UHC in UK, the model is NHS, as I previously mentioned as well. So National Health Service, which is NHS, provides the publicly funded tax-based healthcare systems. And what included in these NHS model services, that including the GP services, consultations, emergency care services, hospital treatments without upfront payment. And that this is the responsibility of the NHS system, that they make sure that they should be given in equality, as well as the accessibility of these services should have to be promised to all the population. So during the COVID-19 time, if we'll talk about that one, that there was like the chaos was there during all the timings. The prices of every medication was going to be high. At that time, NHS made sure that the testing should have to be free, the hospitalization should have to be free, and the vaccination for all the people, for all the residential should have to be make sure that should have to be given. And that gives that minimize the financial barrier, even that was the extreme demand. So sustainable healthcare financing in UK, primarily it is being funded through the general taxation, and for that purpose, that are these taxation is going to be working in a proper way. There is a system like NIC which evaluates the treatment and the drugs for the clinical effectiveness and for the value of their money. What is the goal of NIC? The goal of NIC is to minimize the population health outcome while they are using the limited resource effectively. Practical example, as we knew that cancer treatment and cancer drugs are very expensive, so there is need to be test them before giving and putting them into the market, so that no extra money should have to be spent over them. So expensive new cancer drugs are funded only if they are demonstrated clear survival benefits and the cost effectiveness. However, government is and NHS is providing a lot of effort to give treatment to people. However, it's not possible to put all the burden to the healthcare system on NHS. So there is a provision of like private health insurance. What is the role of private health insurance? This is a supplementary option for faster access to elective procedures. It is a mixture of it's a mixed system, like government system, mixture of the private insurance that provides that if somebody needs to make their procedure quickly, like for elective procedures, or you can say they wanted to cut down the time duration, the list time duration, they can use these services for betterment of their treatment. So provide the ensure this mixed system provide equality, private insurance, which provide flexibility. In London, residents use private insurances to reduce waiting times for elective surgeries. Meanwhile, they use NHS for their emergencies as well. Governance of the UK health systems, it is not simple. It's a multi-layered structure which is based on Department of Health and Social Care, which is having the functions to make policies for the overall people. And then NHS England, they have to deliver system that we already policy made. And then integrated care system, which is like they have the function to coordinate different organization, different authorities, to make sure that all the things should have to run in a proper way. So in London, integrated care system integrated hospitals, local authorities, and communities organization for the chronic diseases and care coordination. Governance in healthcare refers to how decisions are made, policies are implemented, and services are delivered. In United Kingdom, the health systems has multi-layered governance system to ensure efficiency, accountability, and population health improvement. So if we talk about like London integrated care systems, in London, ICS have been used to improve the coordination of care, especially for the chronic diseases. What are the key features of that one is the collaboration between hospital, local councils, and communities and organization, sharing the patient data system, joint planning and funding, so that system should have to be run in a proper way with coordination. So what is the public health impact of London ICS? That have improved this disease management outcomes, specifically the chronic disease management outcome, reduces the hospital administration, better patient satisfaction, increased focus on prevention, and efficient use of healthcare resources. They are, if these focuses and these improvements come in any systems, they can lead to the betterment as well. What are the benefits of governance structure? Accountability, equality, efficiency, integration, adaptability. These are the main benefits you can get through this. What are the challenges they are facing in governance? Complex structures can cause delay in decision making, which can lead to delay in treatment plan as well, and giving services to the people as well also be decreased. Coordination between levels may be difficult. Resources can be constrained on the local levels, and variation in services equality across regions can be. Public health perspective, from a public health perspective point of view, governance is essential to deliver population-based interventions, reduce health inequalities, and improve access to care, promote prevention and healthcare. What are the challenges facing by UHC is that whenever the population is going to be increased, ultimately that is going to be putting a pressure on healthcare system. Aging population is increasing, which enhancing, or you can say increasing the demand for workforce. However, the workforce is same over there. So the system, or you can say the balance between population, aging population is increasing and the workforce is decreasing, which is going to be putting a strain, or you can say the UHC is facing challenge of this situation. Meanwhile, the financial crises are still existing. Financial pressure leading to the long waiting list. People need to wait like for the months, so that their time will come and they can be treated. And that also delaying in adopting new techniques as well. UHC and health insurance during special situations. There are existence of some special situations or crisis, you can say them. They are like the pandemic. People were not expecting that one, but when pandemic suddenly surged in a healthcare system and the demand was increased, and particularly NHS faced a lot of crisis at that time as well. And the natural disaster, if you will say, during the time duration of 2010 when Pakistan was being flooded, that flood not only damaged the lives of the people, but meanwhile the infrastructure, the medical services is also being, you can say, destroyed. Wars and political crisis, distribution of health services and displaced population, and economical crisis, which is always exists, reduces the government revenue, impacting the healthcare budgets. Now comes to the solution. Then we came to know that there are the solutions for the sustainable financing, like with the emergency funding, which can continue continue the you can say the services which is being providing, that and proper planning should have to be needed for them. Insurance schemes should have to cover the disaster risk. Digital health system, which is a very good intervention, which make, you can say, reduce most of the burden on all over the healthcare system, so particularly in NHS, so that people not need to travel for a very long time, as well as people not need to people can get their services on time or immediately. International collaboration for the resource sharing should have to be maintained. During Ukraine conflict, WHO supported emergency health insurances and mobile clinics ensured continuity of care for the displaced population. So with the help of like multiple coordination, Ukraine crisis has been overcome as well. Innovation and reforms for the sustainability. Telemedication is very important, as I mentioned earlier, that reduces the time duration, that reduces the cost effectiveness, that is must say that it is cost effective. Digital health system, prevention health care strategies. Instead of spending money on treatment of any disease, we should have to relocate that money to prevent that disease. And public and private partnerships, so that it's a mixture of like government should have to be treat the emergencies. Meanwhile, if the people need to cut down the time duration for getting some elective treatment, they can have their private insurances as well. Economical evaluation and molding to guide the guide to resource allocation during the crisis. So what is the lesson for the global health system? That equality with the help of efficiency can lead towards sustainable UHC. And strong governance with the cost effectiveness can lead towards the resilience during the crisis. Mixed public plus private systems can provide the flexibility while protecting vulnerable population. What will be the conclusion? That universal health coverage is not just a goal, it's a practical necessity for resilient health systems. UK's experience demonstrate that strategies, financing, collaborative government, and innovative solutions are key to sustaining UHC even during the global crisis. Our global health professions will must learn, adapt, and implement these strategies to ensure healthcare for all and for everybody. These are the reference, and thank you.
Hope I'm audible now.
Yes.
Yeah, it's a happy moment for me and the entire JLI family to have a wonderful afternoon for some of us and evening for some of us, and quite a good learning experience. We started with Dr. Tatiana with a very, very pertinent topic nowadays in academia and in almost every sphere of industry, life, social life, everything. AI is transforming everything. So there's a huge AI bubble throughout the world. There's a huge AI interest in almost every walk of life. And in the academia, it's transforming the way we used to learn, the way we used to teach, and it's going to evolve. I would like to share here that AI is still in the incipience. AI is still the beginning. It's in the beginning. Where it's going to reach, ultimately, even AI doesn't know, and we don't know it either. So this may transform our lives completely, and we may need to adapt as things evolve, as for any technology or any advancement which has happened in human civilizations. The other thing which I want to share here today with all the students, all the attendees, and first of all, thanking everybody to be here, is that it's a rare opportunity that students from different countries, different regions of the world, different cultures, and then performing different studies and expressing their ideas, expressing their experiences, experiencing and then sharing their difficulties, the challenges, the wins and the misses they had during their research endeavors. So this is a rare opportunity which can be possible only when you are studying online. Okay, we never got this opportunity when we were young, when we were studying. So this is a learning experience even for us at this advanced age as well. So please take advantage of these sessions. There's a lot to learn from each other and interact as much as possible. We had a wonderful session today. We have one more coming up tomorrow, and I request everybody to be there and to participate, to express views, to critique in a healthy way on each other's experiences, learning, research, and try to learn from everybody. So I really am looking forward for everybody to be there. And then I would like to thank Dr. Anaita, Dr. Blessy, and Dr. Tayyib's plenary session as well. So all, including the IT team, the support team, the admin team at JLI, who have been able to put everything together, and we will be doing such things much more in future. So thank you so much. Everybody have a nice evening and good night. And let's collect all together. Let's get together tomorrow.
On both local and global stages. And her contributions are geared towards the design and evaluation of global health initiatives, integrating policy, economics, and social justice perspectives. So, with this extensive experience in teaching, research, and public health consulting, she advocates for evidence-based, people-centered health systems, focusing on improved health outcomes for marginalized populations also. So, Dr. Youmna, thank you for joining, and the stage is yours. Thank you so much.
I'm happy to be here with this very diverse and interesting community of public health and economics researchers and colleagues. And allow me to share my screen to start the lecture. Okay, can everyone see it? Is it visible?
Yes.
Okay. Sorry. Okay, so as I said, I'm very happy to be here and in this very interesting community where I'm passionate about public health and economy and how these two very diverse areas are connected. So I'm Youmna Abdelnabi, as I've been introduced. And today I will be presenting a case study called One Nation, 100 Million Lives, an economic evaluation of an Egyptian health initiative. Now, before I start, I would like to tell you how personal this case study is to me, as it touches the lives of the people in my country. And it's also very interesting, and I hope you like the talk. Just before I start, I just want to set I want to set the video so I can see everyone. I don't know how to do it. Okay, can everyone still see that, right? Okay. So before we start, I would like to tell you a little bit about Egypt as an economy and as a country. So Egypt has been categorized according to the World Bank as lower middle income country with a population exceeding 100 million people, which means that any national health intervention is immediately operating at an extraordinary scale. And economically, Egypt's GDP per capita remained within the range of approximately 3,000 to 4,000 US dollars. So over the recent years, growth has been steady but still constrained by structural pressure, and health healthcare as an infrastructure, as an institution, it was constantly competing with other national priorities such as infrastructure and education. And from a healthcare perspective, the system has historically been characterized by relatively low per capita spending, which is around $120 to $150 per person annually, and critically, a high reliance on out-of-pocket payments, which accounts for nearly 60% of total health expenditure. So this means that the healthcare system was a burden on the economy, and the hospitals were often, or not often, almost always overwhelmed with advanced diseases and acute cases, and acting in a reactive model rather than a proactive model. So in many ways, the system before this initiative, which started in 2018, it was strained and economically inefficient. And before 2018, Egypt had a dual healthcare burden. It had the burden of hepatitis C virus and also non-communicable diseases. So the intervention, when it started within this context in 2018, it was remarkable because it wasn't just a healthcare initiative, but it also helped the economy a lot. So this initiative started by, instead of starting with a gradual, slow pace, it started with a very bold and rapid and at-scale approach. The initiative included mass screening for hepatitis C and free treatment for all detected cases, along with the nationwide screening for non-communicable diseases such as hypertension and diabetes. This resulted in over 60 million people were screened, and in a relatively short period of time, the people received treatments or management plans for their conditions. So it was a population level intervention, and it eventually helped to shape the economy. Yes, any questions, please feel free to put them on the chat, and I will get back to you at the end of the lecture. Now, as I said, it was a large nationwide scale initiative. Egypt mobilized hundreds of clinics, of mobile clinics, and they recruited almost all of the healthcare workforce in the country to help participate in this initiative and to reach as many as rural areas as possible. Now, all of the data here in this lecture are bought from, or I got them from highly trusted international sources, including the World Health Organization, the World Bank, the Global Burden Disease Study, and alongside the ISPOR, which is a global organization that sets best practice guidelines for health economic evaluation. Now, to evaluate this initiative economically, it's important that we first understand the burdens of both epidemics, both their health burden and their economic burden. And we're going to use a unit of measurement. It's the DALYs, which is the disability adjusted life years, to measure the overall burden of the disease expressed as the cumulative number of years lost due to disability or illness. Now, why does this matter economically, or why should we think of a healthcare initiative from an economic perspective, or why do we do the economic evaluation in the first place? Now, to understand why this matters economically, we have to shift our perspectives from a healthcare or a public health perspective, where we ask how many people are sick or how many people are affected by this disease, to a health economics perspective, where we ask a different question. What is this disease costing the society, or what is the cost of doing nothing to treat this disease? And before 2018, before this initiative, Egypt was not just dealing with illness, it was dealing with a lot of more than illness. Actually, it was dealing with lost productivity, overwhelmed healthcare systems, financial strains on the households because of the out-of-pocket costs, and long-term economic stagnation driven by poor population health. So this is where economic evaluation becomes essential, because it allows us to move beyond describing a problem and instead assess whether an intervention is worth the investment or not. So economic evaluation eventually allows us to compare what we spend with what we gain in health. And in public health, this helps the policymakers and the researchers to decide where to allocate the limited resources. So economic evaluation at its core is about comparing what we spend with what we gain in health outcomes. And there are three primary approaches in health economics that we use to evaluate. The first is the cost effectiveness analysis, where we compare costs to natural health outcomes, such as lives saved or the DALYs averted. So it helps us understand how efficiently an intervention improves health. The second one is the cost-benefit analysis, where both costs and benefits are converted into monetary value, allowing us to calculate the financial returns, essentially asking how much value or how much money did we gain for every unit of currency invested. And the third is cost utility analysis, which incorporates both the quantity and quality of life, using measures like QALYs or DALYs to evaluate the broader impacts on well-being. So in this particular case, I chose the cost effectiveness analysis, the first one, because the primary objective of the intervention was to reduce the disease burden at scale, and DALYs provide the most appropriate measure for capturing the impact. And to make the findings more meaningful, I'm going to use the ROI analysis, the return on investment analysis. Now, to fully appreciate the economic implications, we also need to distinguish between direct and indirect costs. Now, the direct costs are the visible expenses borne by the disease and are seen in the healthcare system, such as hospital care, medications, diagnostics, and long-term disease management plans. These are the costs we typically measure in budgets and financial reports. While on the other hand, the indirect costs are less visible, but often more powerful or have a stronger effect on the economy. These include lost productivity due to illness, absenteeism from work, early retirement, and even premature death. So in the case of chronic diseases, such as what we're discussing here, hepatitis C and non-communicable diseases, indirect costs can exceed direct costs, meaning that true economic burden extends far beyond the healthcare system. We see it in the society. So this is why the disease should not be viewed only from a health perspective, but also we need the economic perspective, where the diseases here and the illness here are seen as a form of economic leakage, reducing the national productivity and growth. Now, from a methodological perspective, as I said, this evaluation will be using a cost effectiveness framework from a societal perspective, meaning that it has to capture both healthcare costs and the broader economic impact, the direct and indirect costs. And the analysis uses long-term horizon extending to 2030 and compares the intervention against a no intervention scenario. Like we're comparing what the intervention did against what if we did nothing, what if we left everything as it is. And a projection-based population model also is used to simulate disease progression, treatment effect, and economic outcomes over time, with dailies averted as our measurement unit. So now, to start with the burdens of the disease, Egypt historically has been one of the highest prevalences of hepatitis C in the world. And as we can see here in a study published in Virus Disease Journal in 2021, they showed that in 2015, the prevalence of hepatitis C in Egypt was the highest than the surrounding countries in the area, and even in countries with a comparable socioeconomic condition. Now, Egypt, this high prevalence of hepatitis C was due to past public health practices, specifically the mass treatment of schistosomiasis, which started in the 1950s. Where they didn't have sterile injections, they still used the glass ones. Sterilization wasn't up at its most perfect status like now. So this led to the widespread transmission of hepatitis C. And by 2015, approximately 6 million people were living with the chronic condition. And the disease was responsible for around 40,000 deaths annually. This makes hepatitis C particularly challenging, also as it has a silent progression. It leads to liver cirrhosis and cancer. So again, other and furthermore indirect costs. Now, as we can see here, that the global prevalence of hepatitis C compared to Egypt, like globally, 58 million people were affected. 6 million of them alone were in Egypt, which represented like a major healthcare strain and high economic cost, which required the need for an intervention. And when we put this together, this is the three pillars of the hepatitis C burden, where millions of people were infected, and there was the silent progression of the disease and the economic burden. So, oh, sorry. Sorry, there's something happened. I'm gonna fix it. Okay, until I fix this, I'm gonna answer just the questions here. The GDP per capita for Egyptian people, it's around 200,000. It's $3,000 to $4,000 per capita. And how did you succeed in engaging government to accept such a nationwide intervention? Actually, it was the government who decided to do that because of certain economic problems that we have that led to Egypt getting funding from the World Bank. and as a requirement for the funding, it has to be invested in the health and the infrastructure of the country. So they came up with this intervention. And yes, hepatitis C was only the massive screening because we have the highest rate of hepatitis C. Hepatitis B is actually more controlled, and the other viruses are more controlled. Hepatitis C, it's like a silent virus progressing, and we have the highest rate of hepatitis C rather than the others. I'm sorry, I'm gonna just fix this 1 second. Sorry.
Dr. Youmna, are you facing any
Yes.
technical issues?
Yes, I have a problem. I don't know. The sharing stopped. I have to like restart the program again, the Zoom again. I'm sorry. Yeah,
Okay, so
just 1 second. I'm gonna
let
fix
me
it.
check. Yeah. So if you want, I can share my screen and your presentation.
No,
Just yeah,
it's
okay.
yeah, it's gonna work. Yeah,
Okay, fine.
it's something related to the teleprompter. So I'm gonna re-upload it. Okay, sorry.
Okay, so in the meantime, I would like to have some feedback for our yesterday's session from any of our presenters or even participants. Any one of you who would like to share your thoughts for yesterday? Any one of you? So did you all enjoy yesterday's session, including our technical session, our plenary sessions, and the presentations?
If I may, I enjoyed the first two sessions. The
First two
presentation.
sessions by Dr. Tatiana, yeah, and
Yes.
second one?
And then I was bumped off the program, and I'm hoping that will not happen today. I could not get back in, even though I reported the problem, but I could not get back in.
Yesterday?
Yes.
Okay, okay.
But the first two I attended, I thoroughly enjoyed. Thank you.
That's great. So what were your learnings? What were your takeaways? We were talking about, all our presenters were talking about key recommendations, the main key takeaways and all that. So what were your takeaways? What do you remember from yesterday's presentations? Anyone?
I can share my thoughts still, if you like.
Yes.
The use of AI in the research, and how, even though prevalent, is now being more streamlined, more regulated, if you like, by the researchers themselves instead of by people from outside, and the importance of it, ethically and otherwise. It was really touching to see the research that was done and how Dr. Tatiana presented it.
Okay, so I think Duo has something to say. AI can be guided by the presenter or researcher because it can make mistakes. Yeah, right. That's true. Okay, so I think Dr. Yomna is back.
Yes, yes,
Yeah.
yes. Okay. Okay, I'm sorry for this technical problem. Okay.
Yes, Dr. Yomna, your presentation
Yes,
is visible.
it's
You can
visible.
you can start.
Okay.
Yes. Yes, you
Okay.
can start.
Okay. So, so we discussed the, I'm sorry. Okay, so we've discussed the impact of hepatitis C or the burden of it. And now to translate this into DALYs or the economic burden of it, we can see here that that the DALYs before the initiative, they reached around 463,000 dailies lost. This means that millions of people were living with the disease. And if we hadn't had the initiative, it would have reached. Okay, I'm sorry, I'm just checking the messages. Okay, that's fine. Okay, so the DALYs reached for 463,000, and if it wasn't for the intervention, it would have reached, like, again, we said that we have projections until 2030, sorry, so it could reach like 600,000 dailies, meaning more and more people living with the disease and living with disabilities. Okay. I'm sorry. I'm having a problem with my teleprompter. Okay. So back to this slide shows the actual economic impact of the problem, where hepatitis C patients, as I said, most of the patients here are in rural areas where they do not have health care, or some people don't even know that they're living with the disease. So that was the problem. So it had a major liver complications treatments. So instead of treating hepatitis C, most of the people were dealing with liver cancer and liver cirrhosis, and eventually productivity loss and death. So here I want to hide this. Okay. So here we can see that the total economic burden by 2015 actually reached $3.81 billion. And this translated into like the DALYs translated into money, it meant like $700 million per year were spent only on the direct healthcare costs. Sorry, again, these are the direct costs only. So imagine the indirect costs that we were dealing with. And the projected burden, if we hadn't dealt with these diseases and we hadn't had this initiative, it would have reached $89 billion by 2030. So here you can see that we have like the whole like shaped in front of us, that the dailies were 460,000 annually, but after the campaign, it dropped to 200 or 300 to 200,000 dailies per or 200,000 dailies averted, we can say that, which means that by 2030, almost the dailies will reach almost 60,000 dailies, which is a major accomplishment and a huge drop in the numbers of the people living with disability and the illness. Also, at the same time, Egypt was facing a growing burden of non-communicable diseases, which accounts for approximately 85% of all deaths in the country alone. Of course, these conditions, most of us know non-communicable diseases are cardiovascular diseases, cancer, diabetes, of course, both types, and chronic respiratory diseases. So, I'm sorry, diabetes type 2, not both types. Diabetes type 2 is the non-communicable one. So they disproportionately affected individuals, not with equal numbers. As we can see here in the slide, the cardiovascular diseases accounted for 46% of all the diseases in the country. Cancer 14%, 4% of the 4% for the chronic respiratory diseases, and diabetes for 1%. Of course, all of these are caused by a lot of risk factors such as tobacco use and sedentary lifestyle, unhealthy diets, and harmful use of alcohol with the tobacco. And before 2018, these diseases were already consuming a significant share of healthcare resources, while also driving productivity losses at a national level. Okay, so someone is asking, can you explain more detailed about the hepatitis C massive screening and the treatment provided to make the program success? Okay, so the screenings, the government allocated hundreds of mobile clinics, like it's basically a clinic with the laboratory, and we have a whole staff on the clinic. They were moving across the country. They were doing blood tests to people, and whoever tested positive for hepatitis C, according to the stage or according to the doctor's diagnosis, like if he's an early stage or a late stage. Early stage people are usually treated with there's an RNA targeting medicine. It's basically pills. The whole like treatment plan is given, like if he is to take like 10 pills, for example, or 20, he would be given the whole treatment package for free. And if he is more advanced, we have several across the country, several hepatic hospitals only specializing in hepatitis diseases, where they would be referred there and also receiving treatment for free. I hope I answered the question. Why only hepatitis C, not other blood transmissible infections? Because again, Egypt is a very limited resources country, and we dealt with, like, we had priorities. I'm not saying that other transmissible diseases we take it lightly. No, of course not. But again, hepatitis C is one of the major problems in our country. It's transmitted through hairdressers and barbers. It's a lot of people in these areas, they don't know that they're infected, and so they go to other doctors, like do dental procedures or give birth or whatever, things that have blood. they don't tell or they don't know that they have hepatitis C, so they end up infecting like a whole hospital or a whole community. So again, they dealt with hepatitis C because it's the most dangerous thing here. And because also we have limited resources and funding, so we give priority to hepatitis C and non-communicable diseases because they're the most like major two issues. And hopefully after 2030, we will move on to more serious diseases. According to the annex report, this is like an economic report that is about, it's published on a yearly basis about countries. We can see here that the non-communicable diseases have a high prevalence, which is 85%, compared to the 70% worldwide. They're known as the silent killers in Egypt. They're cardiovascular diseases, cancer, respiratory diseases, and diabetes. They, of course, lead to lower productivity, loss of productivity, and premature death. All of this was affecting the economy and draining the economy, actually, because like 30% of the population have hypertension and 63% are overweight, which makes them more susceptible to these diseases. Sorry. And according to the global burden of disease, the nearly 44% of total deaths in Egypt were due to non-communicable disease, which qualifies for or makes translated into 82 to 85% of the total deaths in the country. So the economic burden of the non-communicable diseases was both in the direct and indirect costs. The direct costs were low per capita health spending and very high demand on services like insulin for diabetics is not insured. They filed for insurance, and so as the heart procedures and so on. So they were straining the hospital and the long-term care facilities. And of course, there was a strain on the medications because they're not easily available in our country, again, due to the economy. And also out-of-pocket burden, which was around 60% of total health expenditure. So because people, again, were not insured. So households personally financing chronic diseases made a whole different level of burden on these households. And many faced catastrophic health expenditures because dealing with non-communicable diseases is really expensive in our country. And of course, the indirect economic burden, which is the living with a disability, loss of productivity, increased absenteeism from work, or even reduced workforce participation, people can't work, and premature mortality, leading to declining of productivity and slower economic growth, and of course, increased dependency burden. This slide here captures the diaries of both the hepatitis C and the non-communicable diseases, so everyone could gather like the big picture. So before the initiative, 463,000 deaths alone were caused by the disease, by the hepatitis C, and around 15 to 18 million deaths from the non-communicable diseases, which is 44% of the total disease burden. Now, as we can see here, that before the initiative, before 2008, there was a peak in the deaths, and the pre-intervention daily burden reached 16 million deaths, which dropped to 15 million after the intervention, which is around 800,000 deaths, which is still a huge number, equivalent to nearly 1 million years of healthy lives saved. And also there was a reduction in the premature mortality, and which, according to the evaluation here, by 2030, this initiative should have reached approximately 40% of achievements, which is like 40% of elimination of the burden, not elimination of the disease, but here when you say elimination of the burdens, because non-communicable diseases mostly are not cured, but are properly managed in this case. And to translate this into the cost effectiveness model that we said, analysis that we said we are going to use. So you can see here that the costs or daily saved according to the economy or from an economic perspective were approximately $584 per capita or per dailies averted, in addition to the GDP-based cost threshold, which were originally Egypt's GDP per capita is $3,000 to $4,000. So this led to highly cost-effective, high costly effectiveness, because the GDP per capita here it's much less than the country's GDP per capita. So to explain it more for the public health fellows that not into economy, that like 584 is way less than 3,000 and 4,000. So this means that we've saved a lot of money. And from the public health perspective, of course, it was very efficient because a lot of people were actually aware that they were sick. Most of the people, the diabetics or the heart diseases or the hepatitis C patients, they were not aware. So knowing that they have this disease is the first step to getting cured, and offering free treatments. And for the non-communicable diseases, they were offered a lot of free checkups and screening procedures, laboratory works and stuff. Maybe the insulin and the heart medications are not fully available for free, but still at a reduced cost. So to sum it up, the daily intervention costs versus the GDP threshold was a major success because it was exceptionally efficient. And it was almost 46% of savings, less cost effective, and it was only considered cost ineffective for almost 8%, which is an acceptable error or an acceptable mistake in such a big initiative and a nationwide scale initiative such as this one. So the massive health gains were $584 per dailies averted. Now, here we can see the total impact of both the non-communicable diseases and the hepatitis C on the economy, where the initial investment was $230 million. This was taken from, unfortunately, it was not from the country totally. We received a lot of fundings from the World Bank, from the United Nations, the World Health Organizations. We even received some fundings from Novartis and Pfizer. It wasn't a funding, it wasn't a loan, as it was a loan, sorry, it was like a loan, not a funding, it was loan to be returned. So in total, there were $230 million in investment. And this had to deal with the high premature mortality and high healthcare costs and the massive economic strain, which led to a success where the return on investment was almost 35% return, with savings almost $950 million. So we can see here that the economic burden reduction, it was reduced up till 35%. So this means that it was a one-time investment with a long-term economic gain. And to put together everything, I'm gonna like re-say or re-explain the direct costs, resum them, the direct costs, indirect, and the return on investment. So for the direct costs, we can see here that before the initiative, there was high demand on the hospitals due to late-stage diseases and the need for hospital care. But after the initiative, the cost dropped from $312 million to $55 million annually, predicted to be by 2030. So the system moves from treatment heavy to prevention driven, and also it's on its way to moving from being a reactive model to a proactive model. People are starting to be more aware of the signs and symptoms of some of the non-communicable diseases. This initiative is accompanied by a large media campaign to take care of your health, to eat healthy, to move better, against some of our cultural beliefs that we have to eat so and so, and movement is not that important. Also, the indirect economic gains were very effective, where hepatitis C, of course, and the non-communicable diseases, they affected the people's working years, leading to loss of productivity, and a lot of people were unemployed. They can't work. Most of the people didn't want to work because they're just too sick and they don't know what's wrong with them. But after the intervention, approximately $4.7 billion in productivity losses were avoided. And we can see here like a visual representation, like before the intervention, the losses were this big, and after the intervention, we were hitting a nearly normal level. So the system moves from economic drain to productivity gain. And in definition of return on investment, this was highly efficient because, again, we invested $230 million, and we received we gained billions in saving in dollars, in lives saved, in the economy. We have more workforce now. So the program became cost effective in short term and cost saving on the long term, which is a major hit for the ROI. And as we can see here, the economic pattern of the initiative was we had the initial investment, followed by health gains, and the health gains translated into economic return. So for the cost-effective analysis, this is considered cost-effective. And for the ROI analysis, it's high on return on investment because eventually 883,000 dailies were averted. The efficiency was economically translated into $584 per daily, which is highly cost effective, and 4.7 billion productivity gains. So it's very cost saving. And this initiative is very remarkable and important for its global prevalence, because it's not just an example of a country that had a lot of resources and fixed what it had. Absolutely, on the contrary, it's a very limited resources country, but with strategic investment and planning and the political will, because without the government's help, we would never reach this far. We started to be on the track or taking the first steps in health equity and economic efficiency. The initiative was mentioned in several articles. Again, Novartis collaborated with the Ministry of Health, and it's been described as a success story in a lot of papers published. It was praised by the WHO, the World Health Organization, stating that we are in progress in eliminating hepatitis C. And as we end this lecture, I would like to reflect on the World Health Day. I would like to leave you with the thought that public health is not a cost center. It's one of the most powerful investment strategies available to any country. And if we invest in health, we do not simply prevent diseases, but we unlock productivity and strengthen the system, and we can save the economy.